After cycles of aggressive chest compressions and rounds of injected adrenaline, the medical team exhausts their options. The patient's cardiac activity drops into a continuous flatline, and the attending physician officially calls the time of death. The team steps away, and the room goes quiet. Then, a few minutes later, the impossible happens. The abandoned patient spontaneously regains a pulse and begins breathing on their own, completely unassisted. Medical literature classifies this rare event as autoresuscitation, commonly referred to as Lazarus Syndrome. Globally, fewer than 80 cases have been formally published. However, clinical consensus points to massive underreporting. Diagnostic ambiguity and intense fears regarding legal and institutional liability keep many of these events out of the official record. There is nothing supernatural about this. It is a highly specific mechanical chain reaction built on delayed physiological dynamics. It introduces a severe biological paradox. The exact medical interventions designed to restart the heart are the very mechanisms physically preventing it from beating. In these specific patients, the medical act of giving up is the exact biological trigger required for survival. To understand how this works, look at the physics of the human chest cavity during a code. In the rush to deliver oxygen, aggressive manual ventilation frequently pumps air into the patient too rapidly and with too much force, which physically prevents the lungs from fully exhaling. This cross-section shows the lungs next to the vena cava, the main vein returning blood to the heart. When rapid ventilation traps air, it drives up pressure. Expanding lungs physically crush the adjacent vena cava, pinching it shut. With the primary venous pathway blocked, blood flow returning to the right atrium drops to zero. Without blood to pump, cardiac output ceases, leaving the patient in pulseless electrical activity. When the team stops CPR, the trapped air escapes. The lungs deflate, the vena cava opens, and a heavy flow of blood rushes directly into the heart. Stopping the rescue effectively uncrushes the vascular system. It restores the heart's blood volume, known as cardiac preload, allowing its intrinsic rhythm to resume. Beyond the physical pressure, a chemical traffic jam is occurring simultaneously with resuscitative drugs. Vasopressors like epinephrine are injected into a peripheral vein during cardiac arrest, but they require active blood circulation to carry them to the heart's receptors. This map of the circulatory system illustrates the problem. During the low perfusion state of CPR, the medication enters the arm, but without strong blood pressure to push it forward, the drugs stall and pool in the peripheral veins. When compressions stop and chest pressure drops, natural circulation resumes. The peripheral blockage clears, and the pooled medication travels in one concentrated wave. Suddenly, a massive delayed dose of catecholamines hits the coronary arteries all at once, flooding the heart muscle with potent chemical energy. This sudden chemical spike acts as an internal defibrillator, triggering delayed myocardial contraction. The chemical resuscitation did not fail. It was stuck in biological transit until the chest pressure was relieved. This delayed mechanical reaction has forced a critical update to modern clinical protocols. This timeline tracks against immediately following the cessation of CPR. Data shows that over 65% of these spontaneous revivals occur specifically within a 10-minute window after life-saving efforts end. Because of this biological reality, standard medical guidelines now mandate that doctors observe a passive 10-minute electrocardiogram monitoring period before making any official confirmation of death. This data chart highlights the outcomes for these patients. Approximately 35% survive long enough to be discharged from the hospital. Crucially, over 80% of those survivors retain a cerebral performance category score of 1 or 2. That score means these patients are regaining consciousness with good neurological recovery. They return to their lives with healthy brain function, despite the prolonged lack of a heartbeat. Death is rarely an instant toggle switch. It is a complex, degrading mechanical process. And sometimes, reversing that biological process requires medical teams to have the incredible patience to do absolutely nothing.